Hi, this is Michael Altos, and we're continuing our discussion of blood. This is recording part 8. There are many risks of blood transfusion and blood product transfusion, and we should be prepared to discuss this with our patients. The first set of risks are infectious risks, and nucleic acid testing has shortened the window between donor infection and pathogen detectability so that we can really weed out as many infections as possible. And probably the largest determinant of the actual risk is how prevalent the disease is in the donor population. So diseases like HIV are actually very rarely transmitted. The risk is less than 1 in 2 million. And that's because the window between when a patient first becomes infected and when we can detect it is only 7 to 10 days. Hepatitis C has a similar window and a similar risk of 1 in almost 2 million. Hepatitis B has a very long window between when patients become infected and when it's detectable. And so the risk of transmitting hepatitis B through a blood transfusion is more like 1 in 300,000. HTLV has a very long window, but a much less prevalent disease. So again, a risk factor of 1 in about 3 million. Other viruses like CMV, 1 to 3%, although this can be reduced by leukoreduction since CMV is involved with white blood cells. Bacterial transmission is actually quite common, about 1 in 3,000 of all transfusions. In platelets, it's about 1 in 15,000, although the risk is less with apheresis, and 1 in about 35,000 with packed red blood cells. Of course, any infectious product can be transmitted, including West Nile virus, Epstein-Barr virus, parvovirus, prion diseases, Lyme disease, parasites, like malaria or syphilis. Next, we're going to spend some time talking about the non-infectious risks. I like to categorize these, and the first category is immunologically mediated risks, and specifically we're going to start with reaction to the antigens on the red blood cells. So the first one would be an acute hemolytic transfusion reaction with an incidence of about 1 in 80,000. This occurs when incompatible red cells are transfused. This leads to hemolysis of the donor red blood cells. Patients can go into DIC, develop acute renal failure, and 10 to 20% of them may die, depending on the volume of blood infused. This can occur with incompatible FFP as well, and then the opposite is happening. The FFP is attacking the recipient's red blood cells, and they're being hemolyzed. Not only does it happen with the ABO type incompatibilities, but it could happen with other antigens including KEL, KID, Duffy, SS, and RH. The most common reason that this occurs is a clerical error. The patient isn't identified properly and the wrong blood is transfused. So it's really an error of process, not an error of the product itself. In these patients, the recipient's IgM antibodies attack and bind to the antigens on the donor's red blood cells. They activate complement and lead to hemolysis, which is destruction of the red cells. Bradykinins are released, which leads to fever and hypotension. Histamine is released, causing bronchospasm, urticaria, flushing, dyspnea, and anxiety. And the hemolysis leads to a release of free hemoglobin, which is a relatively toxic compound. It damages the renal tubules, leads to deposition of these antibody-antigen complexes and thrombi throughout the renal vasculature, and this hemolytic process can destroy upwards of 200 milliliters of blood per hour. Signs and symptoms of an acute hemolytic transfusion reaction include nausea and vomiting, diarrhea, rigors, hypotension, tachycardia, flushing, dyspnea, chest pain, back pain, headache, sense of impending doom, bleeding, and of course we can see DIC, hemoglobinuria, and oliguria. General anesthesia may mask many of these signs and symptoms, so we have to be vigilant when transfusing patients under general anesthesia. Of course, the first step is to stop the transfusion and notify the blood bank right away. Meanwhile, supportive care includes treating their blood pressure with volume impressors, preserving urine output with fluid diuretics and bicarbonate, and anything else we can do to prevent DIC. Labs should be checked, including chemistries, CBC, coags, fibrinogen, fibrin degradation products, haptoglobin, and bilirubin. And this diagnosis of an acute hemolytic transfusion reaction can be confirmed with a direct Coombs test. This figure reminds us of what a direct Coombs test is. A blood sample from a patient who we think is having this acute hemolytic transfusion reaction is taken. In their blood, if it's really happening, they should have antibodies already attached to their donor blood cells. We're going to take this blood and incubate them with anti-human antibodies, that is, antibodies designed to bind to other antibodies. If there are antibodies on the patient's blood, then the anti-human antibodies will bind to them and cause agglutination, a link between the blood cells. So that would be a positive direct Coombs test. Let's just compare that with an indirect Coombs test. In that case, you take the recipient's serum, and what we're doing here is we're looking for antibodies, and we add it to the donor's blood. If the recipient has antibodies that target the donor's blood, we will get binding of antibodies. Then we add those anti-human immunoglobulins, anti-human antibodies, and we'll get agglutination. The indirect Coombs test is what the blood bank does to see if there is an incompatibility between a donor and a recipient. So we've talked about the acute hemolytic transfusion reaction. There's also a delayed hemolytic transfusion reaction with a much higher prevalence of 1 in 1,500. In these patients, IgG antibodies attack minor red blood cell antigens. Again, this could also occur if you transfuse the donor antibodies to the recipient antigens. This doesn't get detected during the cross-match because there's a pretty low serum level of antibodies. And usually patients have these antibodies because of some prior exposure, either from a previous transfusion or exposure to fetal blood if a patient was pregnant in the past. What happens here is that the red blood cells become attacked and they have lysis of red blood cells when they are re-exposed to the patient. And this occurs in the liver or in the spleen, but it doesn't occur acutely, that's why it's called delayed. It occurs 3 to 10 days after transfusion. Patients have much more mild symptoms: fever, jaundice, hematuria, maybe a rash, a puzzling drop in their hemoglobin. They will still have a positive direct Coombs test, but especially in a post-operative patient or a post-hospital patient, some of these symptoms may occur in a patient who has been sick. The treatment here is only supportive care, hydration, and it's usually self-limited. Now, a patient who's having Aloe immunization is at increased risk for a delayed hemolytic transfusion reaction. Aloe immunization occurs when a patient is exposed to new donor antigens, and it ramps up their immune response to those new antigens. And with each transfusion, a patient is likely to get exposed to a few new antigens that they haven't been exposed to before. There's also something called post-transfusion purpura, which is actually quite rare. This happens, purpura are big blotchy purple spots in your skin that happen 5 to 10 days after transfusion. This is due to Aloe antibodies to human platelet antigens. This almost always happens in women who have previously been pregnant and have developed these antigens. And it's actually very dangerous. It leads to destruction of all your platelets. And these patients may need IV immunoglobulin or plasmapheresis to exchange out these antibodies. The next reaction we'll discuss is a different category of immunologically mediated reactions. This is where the patient is having a reaction to donor proteins instead of donor red cell antigens. A minor allergic reaction, which occurs in about 1 to 3% of transfusions, would be an example of this. And we see the usual allergic reaction symptoms: itching, swelling, rash. It can be treated with Benadryl. If they tend to get this a lot with transfusions, we could pre-treat them with Benadryl or steroids. And saline-washed red cells may help decrease the risk because we're washing away some of those donor proteins. What we're more concerned about is an anaphylactic reaction, which is quite rare. And actually, these aren't true IgE-mediated anaphylactic reactions. They're non-immune anaphylactic reactions, what people used to call anaphylactoid. This is obviously much more serious with dyspnea, angioedema, bronchospasm, hypotension, like a real anaphylactic reaction. But mostly we see this in patients who are predisposed due to hereditary IgA deficiency. We can avoid this again by using washed red cells, or of course if we could identify IgA deficient donors, that would be a good match as well. This can be fatal, so we need to be very careful if we think that there's an anaphylactic reaction going on. We'll stop here and continue the discussion in the next recording.